Hi there, and welcome. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to thank you for joining us for yet another episode of our educational webinar series. Our topic today, postpartum depression, what it is and is not, and what sets it apart from the so-called baby blues that so many new mothers experience. We'll look at the impacts of PPD, how it's diagnosed and treated, and what loved ones can do to support someone with the condition. Our guest is an expert in this topic. Dr. Jennifer Payne is the Vice Chair of Research and a professor at the University of Virginia in the Department of Psychiatry and Neurobehavioral Sciences. She is also the director of UVA's Reproductive Psychiatry Research Program. Jennifer, thanks so much for joining us.
Thank you for having me.
Well, we're thrilled to have you with us. I want to start with a very important distinction here, and that is the difference between the so-called baby blues and postpartum depression. What are the baby blues?
Sure. So, baby blues are really a transient emotional state that most women experience in the few days following giving birth. Many women describe it as feeling weepy and maybe down a little bit, but a lot of women also experience feeling overwhelming feelings of joy and happiness, and they might cry in that situation. So, it's really about being somewhat more emotionally reactive in the days after delivery. About 80% of women will experience the baby blues, and it's very different from postpartum depression in that it does not impact a woman's functioning.
Well, let's talk about that distinction and perhaps kind of move into a definition of what postpartum depression is. How is it defined clinically?
So, postpartum depression is essentially a major depressive episode, as we define in the Diagnostic and Statistical Manual, which is what psychiatrists use to make specific psychiatric diagnoses. And a major depressive episode has very specific signs and symptoms that are present most of the day, nearly every day, for 2 weeks or longer. And those symptoms include feeling down or depressed, not enjoying things the way that someone would normally enjoy them, having negative thoughts and hopelessness, having changes in sleep, appetite, and energy level. Their thought process may be different, and even the development of suicidal thoughts.
What kind of time frame does this roll out on typically for postpartum depression? When does it begin? How long does it typically last?
So that's a great question. And if you ask 10 different people or 10 different sources, you'll get 10 different answers. According to the DSM, the onset of the depressive episode either needs to occur during pregnancy or within 4 weeks after giving birth. Most onsets of postpartum depression occur by 3 months postpartum. So, about 80% of cases with a more expanded definition of postpartum depression occur by 3 months postpartum. And some people use the year after giving birth as a measure of when postpartum depression can occur.
What do we know about causes for postpartum depression?
Well, we know there's a genetic basis. So, some of my early work demonstrated that postpartum depressive episodes actually run in families, and both families with major depression and bipolar disorder in them can have postpartum depressive episodes that appear to have a genetic basis. We think that it's likely triggered by the hormonal changes that women undergo in the process of delivering a baby. There's likely immune system factors that are involved. Stress is obviously involved for those of you who haven't had children. Having a baby is the most wonderful thing you'll do. It is also the most stressful thing that you'll do. And so it's a very stressful process. Sleep deprivation may be involved because babies tend to keep parents up at night. And then there are also psychosocial risk factors. So, having a low socioeconomic status or financial difficulties, not having partner or family support, all of those things can increase the risk for postpartum depression.
Let me circle back to a couple things that you mentioned. The hormonal factors. What do we know about their interplay in terms of how they manifest with this condition?
Sure. So, what we do know is that women who develop postpartum depression have the same hormonal levels and changes in hormone levels that women who don't develop postpartum depression do. And we think it's a sensitivity, a central nervous system sensitivity to times of hormonal change that triggers the depressive episode in susceptible women. Some of my work has looked at metabolites of progesterone, which is one of the hormones involved in pregnancy and the postpartum time period. And those metabolites are called neuroactive steroids. And we think it's likely that neuroactive steroid changes are definitely involved in susceptibility to postpartum depression.
You've done some work in the biomarkers arena as well. Can you explain what a biomarker is relevant to this conversation and what your research has told you about its role potentially in helping determine risk factors for women with postpartum depression?
Absolutely. So a biomarker is some sort of biological process that can be identified either through a blood test or imaging, for example, that is associated with the development of a particular illness. And that biomarker may or may not be biologically involved in the pathophysiology of that illness. So I like to say association is not causation. And so biomarkers are simply biological factors that we can associate with the development of a particular illness or disease state. It may have to do with the underlying pathophysiology, but it might not. The biomarkers that I've identified with my work over the last 12 years or so are called epigenetic biomarkers, which means that there are essentially methylation patterns at several genes that, when they are in a particular pattern during pregnancy, predicts that a woman is at high risk of developing postpartum depression. So we're able to take blood during the third trimester and predict if someone's at elevated risk or at low risk of developing postpartum depression based on these methylation patterns at three genes and with about 80% accuracy.
It's pretty impressive.
Well, it's pretty fun. It means that we can start to move psychiatry from a reactive field to a preventative field. And that's what really excites me about our work.
Well, if I'm understanding this correctly, Jennifer, there's also an element of being able to use this as a sort of a test laboratory for determining risk factors for other forms of mental illness. Is that correct?
Well, I think we're not sure about that yet. We know that women with the biomarkers have higher rates of certain psychiatric illnesses like bipolar disorder and generalized anxiety disorder. But it is not clear yet how these biomarkers function outside of pregnancy and the postpartum time period. So we have a lot of work to do.
Well, let's talk a little bit more about some of those risk factors. What other sort of identifiable things might a woman be looking for in terms of feeling or being targeted, not targeted, but being labeled as a higher risk pregnancy for postpartum depression?
Absolutely. So certainly, if a woman has a prior psychiatric history, especially a prior history of major depression or bipolar disorder, she's going to be at elevated risk. If there's a family history of postpartum depression, so if your mom or your aunt had postpartum depression, that puts you at higher risk. If a woman has had a prior postpartum depression, she will be at elevated risk. If she's off psychiatric medications for pregnancy, she will be at elevated risk. And then there are all those psychosocial factors. So women who are stressed for various reasons will be at elevated risk. And even having a traumatic childbirth will put her at elevated risk.
As you know, one of our goals with this webinar series is to work in as many audience questions as we can during the course of the webinar. And we get some great questions, and a very relevant one just came in that I want to put in front of you here. Do women need to be diagnosed with major depressive disorder or bipolar disorder prior to being diagnosed with postpartum depression?
No. So some women have their very first depressive episode in the postpartum time period. And They may go on to have depressive episodes outside of the postpartum time period and therefore be diagnosed with major depression, or she may go on to have episodes consistent with bipolar disorder. But you don't have to be previously diagnosed in order to develop postpartum depression.
I want to talk a little bit more about diagnosis, but before we even get to clinical diagnosis, can you run through us with some of the signs and red flags might be in terms of early warnings that postpartum depression might be a factor?
Sure. And it's interesting because a lot of women don't recognize that they're depressed in the postpartum time period, and that's because, as I mentioned, it's a stressful time period. You're often not sleeping very much, and you're really just kind of trying to power through. Clues that someone might be having postpartum depression include not being able to sleep when the baby sleeps. So, a lot of women with postpartum depression will feel excessively anxious and will not be able to sleep and will worry that the baby has stopped breathing, for example. Um, really attached to their baby the way they expected to, should be checked for postpartum depression. And then another clue is really just not being able to function in a way that she would normally. So a woman who isn't taking care of things around the home is, barely taking care of the baby, having trouble getting out of bed, not enjoying being with her baby. All of those are signs that she could be suffering from postpartum depression.
I guess the next logical question here would be, when do you know it's time to seek some professional help? And how difficult can that be for women sometimes?
Yeah. So I think if you are at all suspicious that you are having a postpartum depression, it's really important to seek professional help. And many women will say, "Oh, it doesn't matter. What matters is my taking care of the baby." Well, one thing that we know is that there's a very strong and thorough literature on the effects of postpartum depression on the development of the exposed infant. Moms who are depressed aren't interacting with their babies the way they would normally. They don't talk in that high pitched voice. They're not making faces and playing with their baby as much. Even if they have the best of intentions, they are not interacting normally. And that can have effects on the baby's IQ and language development and the development of behavioral problems and psychological problems down the road. So, if you are at all suspicious that you have postpartum depression, you should absolutely get evaluated. It is very difficult to quickly get into a mental health professional's office. There are not enough psychiatrists and other types of mental health professionals in the United States today, and we are shrinking as the population ages. This is part of the reason why I'm really excited about our biomarkers because we can predict who's at elevated risk in pregnancy. And so start the referral process, getting them into somebody with mental health credentials, um, you know, even before they develop symptoms. And so that is one advantage of having a test in pregnancy. That being said, a primary care doctor can evaluate you for depression. Your OB-GYN can and should evaluate you for depression. Even some pediatricians are identifying women who have developed postpartum depression and helping them get in for care. So it's important to reach out to any professional available to you if you think that you're suffering from postpartum depression.
Is there an assessment, a common assessment tool, for example, that docs use to screen for postpartum depression?
Yeah, so there are two that are very common. One is called the Edinburgh Postnatal Depression Scale. We abbreviate it the EPDS. And that is a scale that was developed specifically for use in pregnancy in the postpartum time period. It doesn't measure certain symptoms that are common to depression and being pregnant or postpartum. So, for instance, it doesn't necessarily measure sleep or weigh that significantly in terms of measuring whether you're depressed or not. There's another questionnaire called the Patient Health Questionnaire 9, PHQ-9, that others will often use. And I think either one of those is appropriate in terms of screening for current depressive symptoms.
And as you said, primary care physicians and obstetricians and gynecologists and others can all perform this screening process.
Absolutely, and we're certainly seeing that more and more. The EPDS in particular, or the PHQ-9, is being set up as a routine screening scale that's used in a lot of OB/GYN clinics. And then primary care doctors have been screening for depression uh, using the PHQ-9 and some other scales for a long time now.
And also, as we're talking about reaching out for help, I suppose it's very important for us to also put out what one might do in a moment of crisis, because that could happen during postpartum depression as well. What is your suggestion at that juncture?
So a moment of crisis in this situation is typically either having suicidal thoughts with some intention to act on them. And some women with postpartum depression develop thoughts of harming the child, the baby. Any woman who's having those types of thoughts really needs to call 911 and go to the nearest emergency room for help. We can absolutely help you stop having those types of thoughts. We can get you better, we can get you treated. But that is an emergency, and a woman who's having those types of symptoms shouldn't sit on those symptoms.
So, once diagnosed, what is the next step in the process for treatment of postpartum depression?
Well, much of that depends on the woman, her preferences, what treatment she's had before, and what seems most appropriate given the severity of her symptoms. And treatment can really range from getting psychotherapy, cognitive behavioral therapy, and interpersonal therapy have been shown to be helpful for postpartum depression. But medications are often indicated and perfectly appropriate. If a woman's never been treated before, we often start with SSRIs. But if a woman's responded to a particular class of antidepressants before, we would start with that class of medications. There's also a new group of medications which act on the GABA A receptor. They're called positive allosteric modulators of the GABA A receptor. And there's a oral version of one of these medications that can be taken specifically for postpartum depression.
Question came in about the possible postpartum anxiety co-occurrence with PPD. So I guess the distinction would be anxiety versus depression. How common is that comorbidity?
So it's interesting. The classic postpartum depression presents as an anxious depression. And interestingly, women who have the biomarkers that I've identified all have high levels of anxiety throughout pregnancy and into the postpartum time period. And they're more likely to have received an anxiety disorder diagnosis. So there's something about the postpartum depression that lends itself to anxiety in a good portion of those who develop postpartum depression.
I want to ask you about the role of stigma as a barrier to seeking treatment, because from my understanding, sometimes women might feel like they shouldn't feel the way that they're feeling and are almost embarrassed or ashamed by that sense of depression, for example, and that might keep them from seeking treatment. Is that accurate to say?
That is absolutely accurate. And I think that's accurate across the board. And it's even more accurate in certain populations. And it's a shame because really the best thing a mother can do when she has postpartum depression for her baby is to get treated. But stigma about psychiatric illness in general is rampant, and psychiatry and psychiatric illness is very much misunderstood. Most women feel when they're depressed and they aren't bonding with their baby the way that they would normally, feel like they have failed in some way at being an adequate or a good mother. And unfortunately, when one is depressed, you have elevated feelings of guilt anyway. And so it's just kind of a vicious cycle. And so, the message I want to get out there is, stop feeling guilty and get treated for the most common complication of childbirth. And you're being an excellent mother by seeking care.
Have you found that that message is getting out there more? You've been working in this arena for quite a while. What's the trend line? Is the stigma being addressed more widely through dialogue, for example?
So I think some, I think that there are a lot of things that have not changed over the course of my career. So women are still being given the message that they should not take psychiatric medications during pregnancy. Whereas I think experts in the field really feel that managing psychiatric illness in pregnancy is the way to go, and not exposing the pregnancy or the developing baby to maternal psychiatric illness is safer. But I do think we are talking more and more about postpartum depression. More and more OB-GYNs are regularly screening for postpartum depression and making that part of the regular dialogue surrounding pregnancy and the postpartum time period. But I still think that there is stigma, and we need to keep fighting.
You mentioned CBT, cognitive behavioral therapy. Can you kind of speak a little more specifically in terms of what that might look like, CBT, for somebody with postpartum depression?
Sure. So CBT is really about people's negative thoughts and identifying negative thoughts that go along with being depressed, challenging them, and eventually being able to dismiss them and not engage in negative ruminations that goes along with depression. So when people are depressed, they have a lot of negative thoughts, and they often engage with those thoughts as if they are an absolute 100% reality-based thought. Okay, so when a mother's depressed, she can have thoughts like, I am a terrible mother, right? And the reality is that's probably not accurate. And what CBT does is teach them techniques to be able to identify those thoughts, challenge them, and dismiss them when they're inaccurate.
What about other forms of therapy that might be used along with CBT or perhaps instead of CBT? Couples therapy, for example, is that part of the treatment process?
It can be, and it can be very useful, particularly in the form of educating the patient's partner about postpartum depression and ways he or she can help their partner recover from postpartum depression. Sometimes they're pre-existing, you know, couples issues that need to be addressed that become extremely clear in the postpartum time period. So one of the risk factors for developing postpartum depression is having relationship discord in that primary relationship. And so a lot of times, once there's a baby involved, those issues come to a head. So couples therapy can be really helpful in terms of both education, but also addressing maladaptive communication styles and interactions.
Uh, I'm just looking at the list of questions that's coming in. It's a long list, so forgive me for a second here.
That's
Um,
fine.
a relevant question here is, what advice would you give your husband or support person if they are noticing concerning changes in you? So perhaps we can take that as an opportunity to talk about how a loved one might help uh, get a new mother to seek treatment, for example, or not
Yeah.
necessarily get them to, but support them in that process.
So I think having a frank conversation of, I've noticed that you don't seem like yourself. I've noticed you seem to be really struggling. Have you thought about postpartum depression? I understand that it's the most common complication of childbirth. Maybe we should see if you can be evaluated. Let's go talk to your OB-GYN. I'll go with you. I'll drive you. I'll make the appointment. Anything you can do to like help further that process. Now, that doesn't mean that you bully a woman into seeking care, but it does mean expressing concern and supporting her and getting that care can be really helpful.
Question came in as well about research on postpartum depression and homicidal thoughts, and what are some early signs or symptoms?
So I will say that homicidal thoughts are pretty uncommon in postpartum depression. They do happen, and we do have these tragic stories that make the news. And therefore, doing research on these thoughts and other associated symptoms is hard to do. So it's hard to get a large sample size, right? Um, and that being said, I think when women are having severe depressive symptoms um, and um, and are expressing thoughts that are really not reality based, she's at elevated risk of having homicidal thoughts. I always encourage providers to directly ask, are you having any thoughts of harming yourself? It's really common to have thoughts of harming yourself when you're depressed. And some women have thoughts of harming their children when they're depressed. Are you having those thoughts? Are you having anything along those lines? And really exploring those answers and making sure that you're clear that this woman is not having those types of thoughts.
And again, as you referenced earlier, if this is a point of crisis, it's a time to reach out for acute care at that point as well.
Absolutely.
Is caring for both a newborn and an older child a risk factor for postpartum depression?
That's a great question. There was a study a long time ago that showed if you had two or more children under the age of 5, you were very likely to develop postpartum depression or kind of depression for several years because it's a tough job. Um, some of my work has shown that having a twin pregnancy carries an elevated risk of postpartum depression compared to a singleton pregnancy. I think it often depends on that older kid because older children, depending on how old they are and their personality, they can either be a help or a hindrance. And so I don't have a great study to quote on that particular statistic. But again, I think some of that may be unique to that particular family.
Let's talk a little bit about prognosis and expectations post treatment. This is a treatable condition, yes?
Absolutely. It is absolutely a treatable condition. We occasionally run into someone who is what we refer to as treatment resistant. And sometimes we have to get creative about medication regimens and other types of treatments. But this is a very treatable illness and really should be identified and treated as often as possible.
I know this answer is a complex one, and there's not one specific answer for it, but can you help us with perspective in terms of how long this treatment should typically take?
Yes. So in a woman who's never had a prior major depression or bipolar disorder diagnosis, she's never had a depressive episode before, we recommend treatment for at least a year. And I always recommend that if a woman wants to try to come off, and this is with standard antidepressants, if she wants to come off of a standard antidepressant, that we pick our timing accordingly. So, for example, coming off an antidepressant during the holidays is not the way to go. It's much more likely to be successful if we come off of an antidepressant during a non-stressful time period. Now, that being said, this new medications, the GABA A receptor positive allosteric modulators or PAMs, really require treatment for 2 weeks at a time. And so a woman can take one of these newer medications and take it just for 2 weeks and then come off of the medication. Now, whether she stays well or not is another question and is a very individualized question. Some women do very well for the next year, and other women will relapse with a depressive episode and need other types of treatments. If a woman has a history of depressive episodes prior to the postpartum depression, had 2 depressive episodes, we recommend that that patients stay on antidepressants indefinitely. And
Jennifer, you cut out there for a
oh,
second, so let
sorry,
me ask you just to back up a minute and sort of
yeah,
repeat that answer because it was a good one, an important one.
sure. So, did was the part about the year-long treatment for a first-time episode of postpartum depression understandable?
I believe it was.
Okay, so I won't repeat that. The new positive allosteric modulators of the GABA A receptor, or the PAMs, um, only require treatment for 2 weeks at a time. And if a woman responds to the PAM, then she may just need 2 weeks of treatment. But some women will go on to relapse with a depressive episode and may need more standardized treatments. In general, if a woman has had a previous depressive episode prior to her postpartum depression, that would mean that she's had two depressive episodes. When someone's had two or more depressive episodes, we generally recommend ongoing antidepressant treatment for the foreseeable future.
I want to look at the flip side of this, some of the consequences of not getting treated, because I know a big part of your awareness advocacy is helping people understand the benefits of doing this treatment. What are some of the repercussions of untreated postpartum depression, but both for the mother and, as you've noted, for the newborn?
Well, absolutely. So first of all, being depressed is terrible. You feel terrible, you feel negative, you feel hopeless about the future. It has repercussions, medical repercussions. So if you take two women who, one of whom has depression that's untreated and one who's not depressed, and they have the same stage of breast cancer, the woman who's depressed is more likely to die of that breast cancer. So, depression has profound effects throughout the body on the immune system, on inflammation, et cetera. And so, treating depression is really important, just like treating cancer or diabetes is. In addition, when women are depressed, I always say when mama's not happy, nobody's happy. Being depressed in a relationship can lead to relationship discord. So it puts a strain on your relationship with others, both inside your house and even at work or with friends. And then finally, and maybe most important, when a mother's depressed, it can have profound effects on her children. We consider, a parent having a psychiatric illness that is untreated in the household an adverse childhood event. And that has repercussions for the mental health as well as the physical health of exposed children. And as I mentioned, when mom's depressed, she doesn't interact normally with her children, and they may have lower IQ, slower language development, and other behavioral problems as a result of not having that normal interactive relationship.
Let me get back to our questions from the audience a little and tackle this list a little bit as well. Does having OCD before childbirth increase the risk of developing postpartum depression?
That is a great question. And the answer is likely, but it also increases the risk of having postpartum OCD. There's a phenomenon of women have an increased risk not only of depression in the postpartum time period, but an increased risk of developing OCD with intrusive thoughts, often having to do with harm coming to the baby. But women can have all kinds of intrusive, obsessive thoughts in the postpartum time period. I'll tell you a personal story. I remember when I had my first child, I was giving her a bath. And we were having a good time, and the phone rang. Back in those days, we had phones, for the household, and I had this intrusive picture of me running to answer the phone, and I thought, oh, that would be terrible. And then the psychiatrist in me thought, oh, well, that was an intrusive thought, and I experienced having some intrusive thoughts about my daughter's safety. And I think if you're at all wired to develop OCD, you can see how that kind of natural process of becoming a mother and being aware of safety for your baby might trigger anxiety and might trigger more OCD symptoms in someone who already has the illness.
Next question. What are your thoughts on using DBT to treat postpartum depression?
I think DBT is a wonderful therapy. I think we should be teaching it in middle school to everybody, and the world would be a better place. DBT is a wonderful therapy. It's the dialectical behavioral therapy, and it combines elements of CBT, which we already talked about, with mindfulness and being aware of your emotions, others' emotions, and responding not from an emotional place, but from a more logical uh, place. DBT is great. It doesn't have as much evidence as CBT in the treatment of postpartum depression, but there's no reason to think it can't be helpful.
What advice would you give to women who fear losing their child if they seek help?
Yes, and we see that fear in particular populations, and really in any population, but it's more prevalent in certain populations. And Again, I would err on the side of saying, you need to get yourself well so that you can take good care of your child, and seeking care should not result and you losing your child. And so talking to professionals, to doctors about your symptoms, those conversations are generally private. And Getting help is the best thing you can do as a mother.
Jennifer, I want to ask you to talk a little bit about proactive strategies that a woman might take, especially if there is a concern that she is in a high-risk group for PPD. Can you talk a little bit about that?
Sure. So, first and foremost, if you have a psychiatric history, which would put you at an elevated risk, you should continue to see your psychiatrist throughout pregnancy and postpartum time period. And you should have a really good, thorough conversation about the risks and benefits of continuing psychiatric medications during pregnancy, and what those risks and benefits look like during lactation. So, having a plan um, preferably before pregnancy, is a really great way to go. Secondly, if you're at elevated risk, and you don't have a psychiatrist, consider getting a perinatal psychiatrist, or mental health professional. So someone who specializes in the perinatal time period. I myself have managed several patients who came to me because they were at elevated risk. I was not necessarily prescribing medications for them, but I monitored them carefully during pregnancy and postpartum. And then, if you are at elevated risk, having frank conversations with your support system, making sure everybody is aware that you're at elevated risk, and asking for their input on how you're doing in the postpartum time period. And kind of, if people are worried, you should agree ahead of time that you will seek evaluation and treatment if necessary.
Let's circle back to the research around these biomarkers and blood tests and so forth. I would imagine that they might play a role in what we're talking about here in terms of proactive strategies at some point.
Absolutely. I mean, that's part of what I find exciting about this research is that we can identify women who are at elevated risk and put into motion a plan to make sure that they get treated when uh, necessary, and potentially even have preventative treatment. So, for example, a woman who had a previous depressive disorder, if she had the biomarkers, we might recommend that she restart her antidepressant postpartum, or even restart it during pregnancy. We might put in a referral to a psychotherapist to make sure that she has extra support, and she could talk to her family about the fact that she has a positive biomarker test. You mentioned stigma before. It's also my hope that having a blood test that is predictive of a future mental illness will help reduce stigma surrounding psychiatric diagnoses.
Great question came in that's also on my list here that I've been wondering about. Can partners experience postpartum depression?
That is an excellent question. And there are several researchers who are really starting to delve into partner postpartum depression. It's a real thing. We are not sure it has the same biological trigger that women with postpartum depression do, but we know that partners who don't go through pregnancy can absolutely develop a depressive episode in the postpartum time period. And that is likely because, again, it is stressful to become a parent. And We know that one of the risk factors for postpartum depression is having a partner who is experiencing postpartum depression after a pregnancy. If mom becomes depressed, it is more likely that her partner will become depressed as well.
Safe to say that that's sort of a frontier for some of this research down the road.
Absolutely. There are a number of researchers who are really starting to delve into this, and I think it's a very exciting area.
Fascinating. You touched on this a couple of times before, but let's zero in on it for a moment here. The question is phrased this way: if a woman has a history of depression and experiences postpartum depression once, what are the chances that she will have it again with future pregnancies?
It's very likely unless she takes steps to prevent onset. So I see a lot of that population of women, so women who've had a previous postpartum depression, and we will often start treatment prophylactically in those women to try to prevent onset.
I want to talk a little bit more about what loved ones can do to support somebody with postpartum depression. And the question, let's broaden it from just a spouse, for example. Uh, Other family members, friends, the community. What are some constructive things that they can do to support a woman who is perhaps in treatment for postpartum depression?
Sure. So first of all, don't say something like it's all in your head or snap out of it. You just need to get organized. That is not helpful. Recognizing that this is a real illness, that there's a biological basis, and that you if she had cancer or a postpartum hemorrhage, you wouldn't be saying snap out of it. So being supportive from that perspective is really important. And then I think much of it is just encouraging complying with care. So making sure that she can get to her appointments, that somebody is available to take care of the baby, even if she's having a telehealth appointment, so that she's not distracted during that appointment with taking care of the baby. And then I think much of it is what every postpartum woman needs, which is community support. Meals can be helpful. Setting up the household so that it's easy for her to eat and drink during the day, even if she's breastfeeding and she can't put the baby down most of the day. Um, Providing a night out or a walk outside of the house without the baby. Just really providing regular postpartum support that every woman needs.
We tend to have a lot of clinicians in our audience for this webinar series. And I want to ask you to speak directly to them because I imagine for what we might call a general practitioner in the mental health world, there might be places where an outside expert would be warranted. I don't know that, but that's my question for you. Are there times when it makes sense to refer out? What do you want clinicians to know about addressing PPD?
Yeah. So I think there are kind of two uh, a fork in the road there, if you will. I mean, one is that every physician should be able to treat basic postpartum depression and depression in general. And you know, antidepressants and the use of them should be part of every physician's repertoire. And so if you see a case of postpartum depression and it seems uncomplicated, it is reasonable to start an antidepressant and not have that patient wait 3 or 4 months to see a psychiatrist. That being said, anything that seems a little complicated should probably see a mental health professional. So, a woman who's depressed, who has a strong family history of bipolar disorder, should be referred because she has an elevated risk of having bipolar disorder, and treatment with an antidepressant might trigger a manic episode, for example. Anybody who is having psychotic symptoms, so hallucinating, having delusional thoughts, those patients should be referred to the emergency room for a psychiatric eval, for an emergency psychiatric eval. Similarly, if someone is actively suicidal, meaning that they're having suicidal thoughts and they have some intention on acting on them, those patients should be referred to emergency room. But if it's straightforward, it seems like it's depression, they're not suicidal, family history of bipolar disorder, every physician should go ahead and initiate treatment while initiating referral to mental health professionals.
And in terms of finding that mental health care, can you suggest any questions that a new mom might ask to kind of screen that provider as to whether or not they're qualified to be working with her on postpartum depression?
So, I think most psychiatrists can handle basic postpartum depression. And where reproductive psychiatrists, which is what I consider myself, really come in are in the more complicated cases. So, someone who's experienced postpartum psychosis, for example, should really be managed by preferably somebody who has experience in reproductive psychiatry. Um, that being said, you can ask about a psychiatrist or a mental health professional experience in this area. Have they received any particular training? There are trainings that are available that help professionals become very competent in this area. There's one through Postpartum Support International. There's the National Curriculum of Reproductive Psychiatry. There are lots of resources out there. So you can ask for what their experience.
You mentioned postpartum psychosis in that response there. How likely is it for a woman to experience postpartum psychosis along with postpartum depression?
So postpartum psychosis can present with depressive symptoms, but it is a completely different psychiatric illness. And it's part of the bipolar disorder spectrum of illness. Many cases of postpartum psychosis appear to have a manic component, so very elevated mood, lots of energy, speaking very fast. But people can also present with some depressive symptoms. But all cases of postpartum psychosis have psychotic symptoms as part of the presentation. In general, postpartum psychosis is really rare. It's something like less than 0.1% of all deliveries. So it's pretty rare. However, it's much more common in women with a pre-existing history of bipolar disorder. So women with bipolar disorder are at elevated risk of having postpartum psychosis, and really need to be under the care of a psychiatrist throughout pregnancy and the postpartum time period.
Here's a question that came in that I think is a real important one for us to address. What should you do if your provider doesn't take your concerns about PPD seriously? How do you best advocate for yourself? And then I might add to that question, do you find that happens very often?
Well, I think physicians not taking women's concerns seriously is a very common phenomenon, unfortunately, and that possibly is maybe even more common for psychiatric concerns because a lot of providers are uncomfortable dealing with psychiatric concerns. So if that happens, I would go to another provider. So if you got that from your OB-GYN, go to your primary care doctor. I would also initiate trying to get in to see a mental health professional, and probably at the same time that you make the appointment to go to another provider. But I think you still want to get evaluated and treated, and it's very important. And so if you're dismissed, I'm terribly sorry, but go to somebody else.
Let's talk a little bit about self-care, and we can springboard off of this question here. What role does sleep play in the well-being of individuals with PPD? It strikes me that that's a great question to ask in terms of what are things that a woman can do to supplement what a doctor might be helping her get through with postpartum depression.
Absolutely. So sleep is critically important. And it's a little bit of a chicken or the egg question with postpartum depression. So we know that women with postpartum depression are not sleeping normally or well. But we don't know if that's the cause or the result of the postpartum depression. That being said, addressing sleep can be one of those preventative measures that you can take. So having a clear plan with one's partner as to how night feedings are going to be addressed, or how sleep is going to be addressed. And then I also think it's important that if a woman's having postpartum depression and she's having trouble sleeping, that she talk to her provider about what she can do to maximize her sleep. And that can include kind of a plan with the partner, but it can also include medications that maybe treat both depression and make you sleepy, that can be used to kind of kill two birds with one stone.
Very specific question. If a woman experiences a stillbirth and develops depression, would this be classified as postpartum depression or major depressive disorder?
So, um, I- as a research scientist, I would view that as a complicated postpartum depression. It's likely that that woman, if it's a stillbirth, went through the same hormonal and biological changes that a woman who delivers a live infant does. So there's that biological trigger there. It's also complicated by grief. And so that those can be really difficult cases and should generally be addressed both psychiatrically as well as psychologically. So a woman will need to go through a normal grieving process in that situation. Now, what it gets called is kind of up to the provider providing the diagnosis. And I think some providers would call that a postpartum depression, and others would call it a major depressive episode. But from a biological researcher perspective, I would consider it a complicated postpartum depression.
Next question. How much does birth trauma increase the risk of postpartum depression?
So I can't give you a very specific number of it increases from, 10% to
Sure.
20%. Um, but it absolutely increases the risk of developing a postpartum depression. So women who are traumatized by their birth are likely to develop a depressive episode, but they're also likely to develop PTSD. And so anyone with a traumatic birth should consider going ahead and getting some counseling and mental health evaluation to see how they're doing after this traumatic event.
Question came in about substance misuse and self-medicating. Is it more common among new mothers with PPD, and what should we know about that?
Sure. So absolutely. So substance use disorder. One fact to know is that the most common cause of maternal mortality in the United States is psychiatric, and that includes both suicide and overdose. And Which is, I think, a very sad statistic, but is an accurate one. So substance use disorder can absolutely get worse in the postpartum time period. A lot of mothers will be able to not misuse substances during pregnancy, but certainly there are many who do. But if they don't misuse substances during pregnancy, they may go back to using postpartum and they may accidentally overdose in that setting. They've lost their tolerance to the substance. And so that's a very sad situation. I think it's important to screen women for substance misuse and to actively address that during pregnancy and postpartum.
Can you speak to how breastfeeding factors into this conversation on any levels?
Sure. So many women, when they're depressed, may have trouble breastfeeding. And again, that's another chicken or the egg question. Are they having trouble breastfeeding because they're depressed and they're not motivated? Or is it that they're having a brain illness and their brain is not functioning quite correctly in order to promote normal lactation? And so it's a very common phenomenon that women with postpartum depression may have difficulty. Many women, when they have, even if they're identified as having postpartum depression, are reluctant to start medications while breastfeeding. And yet they don't really realize the significant risks and the thorough literature that has really demonstrated over and over that their being depressed is a much bigger risk for the infant than being exposed to antidepressant medication in breast milk. Um, Another common scenario that comes up with lactation is a woman may have taken an antidepressant during pregnancy and then feels like she can't breastfeed um, because she's continuing to take that medication. Whereas the baby was already exposed in pregnancy, there's no reason to not breastfeed, or there are very few medications that we don't recommend during breastfeeding. So I think it's important that women understand that they can take psychiatric medications during pregnancy and breastfeeding, and that it's often the better choice in terms of promoting positive outcomes for their pregnancy and their baby.
And that's a question that they can address with their physician at the time when they're discussing that as
Absolutely.
well, correct?
Yes, have a thorough conversation with your provider.
We're just about out of time. Amazingly, this hour has flown by.
It
But
really
I
has.
want to ask you for some resources that you might recommend for our viewers who would like to learn more, whether they're clinicians or spouses or women who have dealt with postpartum depression or perhaps are dealing with it right now. Do you have any particular books or organizations that you recommend for additional details?
So I absolutely recommend Postpartum Support International. They have resources both kind of on a national level, but also on a regional level. So there are, various states have kind of postpartum support international organizations that can give referrals to local mental health professionals. And so that's a really important reference. There's also a maternal mental health national hotline, which I don't have the memorized, but you can look that up. And so any family member, the woman herself can call and again get resources for care and treatment. For physicians in the audience, I strongly recommend looking into the National Curriculum on Reproductive Psychiatry. They have free modules available for training on dealing with perinatal mental health. And again, I think every physician should be able to treat basic perinatal postpartum depression.
And then finally, I'd like to leave things on a positive note here. We've covered a lot of ground, and this is a very difficult topic, I think, for a lot of folks. You've been doing this work for a long time, and it sounds like you've seen some great results from proper treatment. Can you speak to that?
Absolutely. So, a lot of women who develop postpartum depression will respond fairly quickly and fully to antidepressant treatment and to the support that they need. And there's a real joy in treating a woman with postpartum depression and getting her all the way better and seeing her interact with her children and watch those children start to grow and thrive. So this is a very treatable illness. It's a real pleasure and it's an honor to treat these women. And just know that you can get better if you're suffering from this illness.
Jennifer, thank you so much for your time. We covered a lot of ground again here, and I think you did a fabulous job of shedding some light on a very important topic. So please know how much we appreciate your time and your expertise.
Well, thank you for having me. I really appreciate it.
Dr. Jennifer Payne. To those of you watching, thank you for your interest in our educational webinar series. We hope you'll come back for our future sessions, and we wish you a wonderful day.